Hello, my name is Helen Jordan. I'm an intensive care and anaesthetic registrar in the southeast of Scotland. And I'd like to thank you for the opportunity to share our findings on the point of care echocardiography and thoracic ultrasound in the management of critically ill patients with COVID-19 disease. I'd like to mention the 4 other authors of this paper: Hannah Preston, David Hall, Hugh Gifford and Professor Michael Gillies, also from the southeast of Scotland. So we'll start with some background first of all. The first case of COVID-19 disease was identified in Wuhan in China in December 2019, and it quickly spread to other parts of the world, with the first UK case being confirmed on the 31st of January 2020. And intensive care units faced many challenges over this time and continue to face many challenges. This was an unknown disease process, and the management and the pathophysiology were unclear at the start. There were case reports from China of cardiac involvement, including arrhythmias and myocarditis. And also the fluid status of these patients was often quite unclear, with many patients presenting quite markedly hypovolemic. Examining these patients was challenging due to having to wear PPE. And also we had limited resources due to the high number of patients being admitted. We had to restrict the number of specialties coming into the intensive care area, and also these patients were particularly unstable and therefore challenging to transfer them for further imaging in other places in the hospital. So for these reasons, there was a lot of interest in the use of point of care ultrasound in the assessment and management of COVID-19 disease. And the preliminary experience that emerged from China and also Italy described really quite distinctive thoracic ultrasound findings, which are pleural thickening, focal, multifocal and confluent B lines, consolidation, and actually very few pleural effusions in comparison to the general ICU population. The echocardiographic features of COVID-19 came from initially a very small case series and included global or regional impairment of the left ventricle, right ventricular impairment or dilatation, and also signs of pulmonary hypertension and myocarditis. And on the back of these early reports, the Intensive Care Society made a recommendation that critical care clinicians were trained in the use of lung ultrasound and also focused echocardiography for the assessment of patients with COVID-19 disease. NHS Lothian has 3 critical care units, which at the peak of the pandemic expanded to a capacity of 52 beds. Point of care ultrasound is already well established in the care of our patients. We already have established education and governance structures, and we have actually previously reported on our experience of using focused echocardiography in managing non-COVID-19 critically ill patients. So we set out to report our experience of using point of care ultrasound in critically unwell patients with COVID-19 disease, and then describe the principal findings and also their impact on patient management. In order to do this, we retrospectively collected data between the 1st of April and the 1st of May on all patients admitted to critical care with COVID-19 disease, either confirmed by PCR or by strong clinical suspicion. We were able to record patient demographics, the indication for the scan, the level of training of the clinician performing the scan, principal findings, any changes in clinical management, and also outcome data. We also collected information from ventilator settings and any evidence of pulmonary arterial thrombosis, either from CTPA or from post-mortem, which would have been performed as part of the ICE-CAP study. Over this 1-month period, we documented 55 transthoracic echoes, which were performed on 35 patients. And we found 32 thoracic ultrasounds, which were performed on 22 patients. 53% of the scans were performed by consultants, and all clinicians had completed either FICE or CUSIC accreditation or had a higher qualification, such as BSE. The patient demographics were very similar to the UK-wide ICNARC data. We found that 51% of patients had no cardiovascular comorbidities. Of those that did have documented comorbidities, 37% of those was hypertension only. This cohort of patients had a 30-day mortality of 43%, a median ICU stay of 20 days, and a median hospital length of stay of 24 days. All intensive care clinicians who performed either the echo or the thoracic ultrasound had a minimum of the focused intensive care echocardiography accreditation. As the name suggests, this is a focused examination, and it is designed to answer these 5 questions. Many of the intensive care clinicians in the southeast of Scotland do have more advanced qualifications, including BSE, and therefore we were able to document additional findings as well. As I mentioned earlier, we have previously reported on the use of focused echocardiography in the management of critically ill patients. This was published in the Journal of the Intensive Care Society in 2017. What we were able to show is that it is feasible for intensive care clinicians to undergo basic training in echocardiography and to be able to gain useful and reliable information about patients and use it to change management. This also gave us the opportunity to compare our findings from 2017 with the general intensive care population to then the findings during the COVID-19 pandemic. So overall, 64% of scans identified some abnormality. The most common finding was significantly dilated or impaired right ventricle, which was found in 44% of scans. And this was really quite a significant difference in comparison to the general ICU population, where only 7% of scans found right ventricular abnormalities. The next most common finding was evidence of hypovolemia, which was found in 22% of scans, evidence of pericardial fluid, which was in 15% of scans, and significant left ventricular impairment was only found in 9% of scans. And again, this was quite different to the general intensive care population, where it was found in 27% of scans. There was very little pleural fluid found, so only 1 scan, which was accounted for 2%, so again a lot less than the general intensive care population. Additional findings were that there were 5 scans which showed evidence of a possible thrombus or a mass in the right atrium. 2 of these went on to be shown to be a pulmonary arterial thrombosis on CTPA. In the COVID cohort of patients, there was a change in management following these results in 71% of cases, which was a lot more than in the general intensive care population, which was 47% of cases. We were particularly interested in those patients who were found to have right ventricular dilatation or impaired function, and we wanted to see if there were any differences between those with a normal right ventricle and those with right ventricular dysfunction. We found that right ventricular dysfunction did not seem to be associated with difference in oxygenation or PCO2. There was a trend towards lower PEEP, and this finding was of uncertain significance, and it may just have reflected a reluctance to use higher levels of PEEP due to the high hemodynamic compromise associated with right ventricular dysfunction. The presence of right ventricular abnormalities was also associated with a higher admission Apache 2 score, and so therefore it may reflect more severe disease. 25% of patients were found to have pulmonary arterial thrombosis on CTPA or at post-mortem examination. This is actually a much lower incidence that is otherwise reported in COVID-19 patients, with cohort studies finding 35 to 45% of patients who underwent imaging had pulmonary arterial thrombosis. This is significantly higher than the previous reported rate of thromboembolic events in critically unwell patients, with around 5 to 15% of the general ICU population. More patients with right ventricular dysfunction were found to have either radiological or post-mortem evidence of pulmonary thrombosis, but this was high in both groups, and so it was not statistically significant. Also, not all of our patients in the series underwent CTPA or post-mortem, and it is possible that some cases were therefore missed. Following focused echocardiogram, there was a change in management in 70% of cases. The majority of change in management was further imaging, including CTPA or formal echocardiogram. Other changes in management included change in fluid management, such as fluid administration or removal of fluid, either pharmacologically or via CVVHD, and also changes in medication, such as thrombolysis or initiating vasopressors. I will just very briefly mention the thoracic ultrasound results that we documented. So all scans showed lung sliding and pleural thickening and B lines present. 71% had multifocal B lines, which is suggestive of severe COVID-19 disease. 74% had bilateral subpleural consolidation. There was only 10% of scans demonstrated pleural effusions, which, as I mentioned earlier, it really is quite different to the general ICU population. There was a change in management in 11 studies, which represented 36%. The majority of the change in management was on the basis that no other cause of hypoxia was found during the ultrasound, such as pneumothorax or migration of the endotracheal tube into the right main bronchus. This allowed for alternative treatments such as pronane or neuromuscular blockers to be given. There are some limitations of this study. So it is a retrospective observational study of a relatively small number of patients, and so the results should be interpreted with caution. It is possible that patients who clinicians were more concerned about and had a higher severity of illness or were deteriorating, therefore had more scans performed. This may have increased the incidence of findings and also the mortality recorded. We also had to rely on clinician-reported findings and changes in management just recorded as free text in the clinical notes. However, we have previously reported in our 2017 paper that when we compared the scans performed by intensive care clinicians using the FICE protocol with formal BSE scans, actually there were no scans where the formal BSE scan contradicted the FICE scan. So in conclusion, echocardiography and thoracic ultrasound performed by intensivists is able to provide clinically useful information which can aid decision making and result in changes in management of patients with COVID-19 disease in intensive care. Right ventricular dilatation impairment predominates over left ventricular impairment, and there is a high incidence of pulmonary thrombosis in comparison to the unselected ICU population. There are many advantages to intensive care clinicians being able to perform focused echo and also thoracic ultrasound. It allows for the rapid assessment of patients using ultrasound if they may be unstable and the diagnosis is unclear. It also reduces the requirement for other specialties to come into the intensive care unit, potentially being exposed to infection, and it also helps to preserve our stocks of PPE. However, it is important that intensive care clinicians understand their limitations and also have sufficient support from cardiology and the echo department, which certainly in the southeast of Scotland has been key to making this service succeed. Looking into the future, we are aware that there is the possibility of a second COVID wave. So we have been increasing the ultrasound capability in our department. Our Echo department has helped us acquire some new equipment. We're offering all intensive care doctors and ACCPs local online training in heart, lung, abdomen and DVT ultrasound, and that's as part of the FUSIC accreditation. And the Echo department is also helping our personnel with mentoring and training, with several looking to gain their BSc level 1 and level 2. So I'd like to thank you for listening and also for the opportunity of sharing these findings with you today. I'd also like to thank all the NHS Lothian staff who completed the echo and thoracic ultrasounds and documented their findings. And I'd also like to make a special thank you to the organisers of this conference, especially for allowing me a little bit extra time to prepare this presentation, as I was a little bit busy with a 7-week-old baby at home. I welcome any questions either via email or you can find me on Twitter, and thank you once again.